Hi, I'm Dr. Neil Shah. I work at the University of California, San Francisco, where I'm leader of the hematopoietic malignancies program within the Cancer Center. One question I'm frequently asked has to do with efficacy or safety considerations of the second generation BCR-ABL kinase inhibitor dasatinib. As I'm sure you know, this drug was initially approved in the second-line setting for the treatment of patients with imatinib-resistant or intolerant disease. It is a very effective agent in the second-line setting, and it's more recently been approved in the front-line setting based upon its superiority at achieving complete cytogenetic response by 12 months when compared with imatinib, which was, of course, the previous medical standard of care for this disease. The drug is, of course, very active, and on the dasatinib versus imatinib study, it appears to be associated with a lower risk of accelerated and blastic phase transformation, which is very encouraging. There are, of course, some patients who nonetheless develop accelerated or blastic phase disease on this drug. The most common cause for loss of response to dasatinib is the evolution of one of a small number of BCR-ABL kinase domain mutations. Of these, we think that the majority of them should respond to agents such as nilotinib. Possibly bosutinib could be active in select cases. Ponatinib, we think, should be active against all the dasatinib-resistant mutations. I would encourage you to look at the NCCN treatment recommendations that draw attention to treatment with respect to specific mutation to help you guide you if you're facing such a patient. With respect to safety concerns, dasatinib is generally well tolerated. We do have known for a number of years that it can be associated with pleural effusion. It's rather unique among the BCR-ABL kinase inhibitors in that sense. These tend to be largely manageable, but it's important to, I think, inform patients of the early warning signs of this. Any new dry cough or shortness of breath should be investigated initially with long auscultation and chest x-ray if necessary, and if necessary, therapy should be interrupted to allow for resolution. More recently, there has been a late occurring side effect that it seems to be somewhere in the less than 1% range of patients that can develop pulmonary arterial hypertension. We don't really have a true sense of the incidence because this was only described in an aftermarket setting. Nonetheless, there appear to be a few cases of this that have been reported in the literature. Interestingly, these seem to be largely reversible, but nonetheless, if you have a patient in whom you suspect they have any breathlessness that cannot be explained by any other cause, including pleural effusion, one thing to consider doing is getting an echocardiogram and looking for elevation of pulmonary arterial pressure there. If it's negative, I think you can rest assured that the patient most likely does not have pulmonary arterial hypertension. If it's positive, you may want to refer the patient for a definitive right heart catheterization to a pulmonologist or a cardiologist.